A very good day to all of you. Today's lecture is actually a two-part series. Part 1 is what I'm going to discuss now. Red and white lesions of the oral mucosa. Now this topic might seem a little strange. Why is it called red and white? Alright, so you will understand it as I go through these slides. The learning outcomes will be okay, so let's go through the learning outcomes. The learning outcomes are list at least 10 red and white lesions and differentiate them based on etiology, classify them and describe etiopathogenesis, clinical features, diagnostic workup, differential diagnosis and management of oral candidiasis, leukoplakia, lichen planus, oral submucous fibrosis. Now I've just listed a very few of them here, but there are a lot more lesions that we will be looking at. But these four we will be looking at in detail. You will see here that there are let me just use the pointer. Yes, you will notice that there are white thick areas here right in the attached gingiva, and that is what I want you to pay close attention to. And those are the white lesions that we are talking about. Appearance of the oral mucosa is categorized as either white or red. Now it's very rare that you see any other colors in the oral mucosa, unless of course there is some kind of pigmentation because of some metal overuse or poisoning. There are very less situations where you see other sort of pigmentations, right? So the most commonest ones are either a white lesion or a red lesion. So the difference why the oral mucosa appears white or red has certain reasons. First of all, it could be because of hyperkeratosis or acanthosis, abnormal but benign thickening of spinosum, stratum spinosum happening, accumulation of fluid either intracellular or extracellular, necrosis, or maybe due to pseudomembrane like fungal infection. Now the reasons why mucosa appears red is because of atrophic epithelium or because there is increased vascularization. That means if you look at these two areas, you will see that white appearance is when, in layman terms, white appearance is when there is thickening of the epithelium, and red appearance is when there is loss of epithelium, right? So moving on, this is the classification I've taken from Burkitt's 11th and 12th edition book, which just classifies red and white lesions based on etiology. They classified as infections, pre-malignant or potentially malignant disorders, immunopathologic diseases, allergic reactions, toxic reactions, reactions to mechanical trauma, and other lesions which don't fall into any of the other categories. Alright, so let's look at each and every disease one after the other, and we'll be covering most of these diseases except for a few less important ones which you can always refer to from the textbook. Right, let's look at oral candidiasis first. It's the most common opportunistic infection. It's called as a disease of the diseased. That means that if there is an underlying condition, you're more likely to manifest with oral candidiasis. 35% of population, all of us exhibit candida in the oral cavity as normal flora, and 50% of denture wearers have denture stomatitis, which is one of the most common causes or one of the most reasons why there is candidiasis in the oral cavity. So predisposing factors for oral candidiasis is difficult for a healthy person to exhibit oral candidiasis as a disease. The general reasons why candidiasis is seen, it could be because of local factors like there's denture wearing, smoking, atopic constitution, inhalation steroids, topical steroid use, hyperkeratosis, imbalance in the oral microflora, quality and quantity of saliva. Systemic factors would be immunosuppressive disease, impaired health status, immunosuppressive drugs, chemotherapy, endocrine disorders, or any hematinic, which means blood deficiencies. So classification of oral candidiasis, you are already familiar with this, is just either a primary lesion or a secondary lesion. The primary one is limited to the oral and perioral regions, where the secondary one is associated with systemic manifestations as well. So the primary ones is the one we'll be concentrating more on. It could be either acute oral candidiasis or chronic oral candidiasis. Now the acute ones could be pseudomembrane or erythematous, also called as atrophic, and chronic could be in the form of pseudomembrane, erythematous again, plaque-like or nodular. And then there are candida associated lesions. These happen because of a mixture of candidal and bacterial organisms together causing the problem in the oral cavity. The examples for these would be dentustomatitis, angular cheilitis, and median rhomboid glossitis. Under the secondary one, there are various diseases. Again, these are divided into diseases which are associated with endocrinopathy or mucocutaneous candidiasis, or diseases like HIV. Let's go to pseudomembranous candidiasis, also called as oral thrush. This is a picture of a 56-year-old female patient on dialysis with neglected oral cavity, appears weak and anemic, and there are large areas of white scrapable lesions which leave pinpoint erythema upon removal. Now this is one of our patients whom we had seen many years ago. If you've noticed that there's a lot of white areas seen in the oral cavity, you would assume that to be food debris, which is natural differential diagnosis, but it's actually oral thrush, which is pseudomembranous candidiasis. And this patient in fact had some underlying condition because of which there was pseudomembranous candidiasis seen. This is erythematous candidiasis, and now there's an interesting terminology called as kissing lesion that's written out here. Erythematous candidiasis again can be patchy or diffuse or restricted to one particular area. Here we are seeing two areas, which is the tongue as well as the palate involved. The reasons again could be an underlying condition or a local disturbances, like for example smoking, or because of usage of antibiotics for a very long time. And here you would see that the palate actually is in contact with the tongue most of the time. So that's the reason why if there's a lesion starts off on the tongue, it's very likely that it spreads to the palate, or if the lesion starts off on the palate, it can spread to the tongue. And that's the reason why it's called as a kissing lesion, because the palate and the tongue are supposed to be in close contact to each other. Chronic plaque type and nodular candidiasis, this is also called as candidal leukoplakia. There is believed to be a role of candida in malignant transformation of this lesion, and that's the reason why it's called as candidal leukoplakia. Now if you look at this, this doesn't look normal at all. There is superficial pseudomembranous candidiasis along with a raised lesion which you're seeing here, which could be associated with plaque-like areas, plaque-like candidiasis, as well as a raised area, nodular area, and this is suspicious for developing leukoplakia in it and should be biopsied. Dentustomatitis, very common lesion. I'm not going into the classification of dentustomatitis, you're pretty familiar with this, but there are three types: minor erythema or restricted to few areas only, diffuse erythema in type 2, and type 3, which is shown in the picture here, diffuse erythema and granular palatal mucosa, a raised granular appearance, typically restricted to the denture bearing area. So like I mentioned previously, dentustomatitis is a candida associated lesion. So there is a combination of both fungal as well as bacterial organisms which lead to this kind of appearance of the oral mucosa. Angular cheilitis, this is again a candida associated lesion. It can happen because of candida as well as staphylococcus aureus, I've written the short form here, which is in high abundance on the skin surface. So 30% of dentustomatitis cases also have angular cheilitis. There are various reasons to why the person develops angular cheilitis in the first place. It could be due to vitamin deficiency, iron deficiency anemia, or simply due to loss of vertical dimension. When we talk about loss of vertical dimension, we mean that in the elderly patients who have lost their teeth, there is a tendency for the arches to collapse, and because of lack of teeth, and hence there is drooling from the angles of the mouth, and that's why it leads to angular cheilitis. Right, moving on, look at this case. It's a 34-year-old Caucasian male who's a heavy smoker, and he comes with an asymptomatic lesion. Where is the lesion? The lesion is on the dorsum of the tongue here, which you're seeing. Erythematous area on the tongue, not normal. Could be called as erythematous candidiasis, but it is having a specific terminology called as median rhomboid glossitis. So the diagnosis of candida in the oral cavity, oral candidiasis, can be done by various methods. Generally, the organism will have to be cultured to make a specific diagnosis. There are various methods of culturing the organism. It could be a smear or a scrape, imprint, impression cultures, or salivary culture, or simply biopsy if you're suspecting features of dysplasia. So this is a method of candidal isolation. I picked this chart from Burkitt's. You can go through it, where it talks about how to do the specific step and what are the advantages and disadvantages of doing it in your clinic. So many of these could be chairside, and some of them might need it to be transmitted to the lab to understand how to what is the kind of colony forming units that you're seeing. And anything above 50, it says here, for example, an imprint culture is a sign that there is a candidal infection. So the management of candidiasis, first of all, local factors should be taken care of. Now when we talk about local factors, we go back to the predisposing factors that we spoke about: smoking, an ill-fitting denture, or someone who's not taking off the dentures at night time. So those kind of factors which need to be eliminated. Fungals, antifungals, they come very handy. The examples you remember from pharmacology would be polyenes. These are, like example, amphotericin B or nystatin oral suspensions. Generally, they are not absorbed from GI tract, and usually the person does not develop resistance to this. So, or you could have azoles in the form of cotrimazole, miconazole, ketoconazole. So these are tablets, and these are gels which are available. In fact, in our clinic, we have cotrimazole and miconazole available, commonly used in the management of oral candidiasis. And chlorhexidine mouthwash, which has mild antifungal activity. It is also it's an antimicrobial and quite effective in dealing with mild oral infections, where you're suspecting a combination of both fungal and bacterial infection in the oral cavity. So all in all, oral candidiasis can be dealt with topical medication first, which should be used, that is either in the form of lozenges or oral suspensions, or a gel or a cream. But if in case it is resistant to all of these, or stubborn infections which are not reducing for more than 2 weeks, then you might want to go on for systemic medication. Right, so moving on, now we've just started off with the diseases where we're talking about infections first. So the first one is a fungal infection, which can appear as a white lesion or a red lesion in the oral cavity. The next one is hairy leukoplakia. Now from your third year knowledge, oral pathology knowledge, you're already aware that hairy leukoplakia is actually not leukoplakia. It is an Epstein-Barr virus infection. And whenever the word hairy leukoplakia comes to your mind, the first thing that you should remember is this classical appearance of white non-scrapable lesion seen on the lateral border of the tongue. It could appear in other parts of the tongue, but this is one classical image which should just come to your mind first when you think about hairy leukoplakia. Is associated with low levels of CD4 and T4 lymphocytes, and hence it serves as a marker for immune suppression. That means if a person manifests this in the oral cavity and you're suspecting the person to have HIV, then if this subsides after heart treatment, then it is an indication that probably the HIV is the person is responding to the medication given to HIV. I hope you remember what HART is: highly active antiretroviral therapy. The differential diagnosis for this kind of appearance, when it appears in the oral cavity, is naturally leukoplakia, plaque type of leukoplakia, and chronic trauma, which is in the form of morcicatio. I'll describe this later on. We'll discuss this later on in the chapter. So this appears completely white and it is non-scrapable. And remember, it is not leukoplakia and not having any malignant potential. It is a viral infection, and when the person's immune response improves, it will subside. Next, let's come to the mammoth, which is oral lichen planus. There's a lot to talk about this disease. It the term lichen actually originates from a symbiotic organism which is composed of algae and fungi. This is a picture of Oral Lichen planus, which is seen on sorry, not Oral Lichen planus, the term lichen, which is used for these algae or fungi which grow on trees or stones, for example. The etiology of Oral Lichen planus is largely still unknown. So it is believed to be an immune pathologic lesion with auto-reactivation of T lymphocytes. Stress plays a very important component and is also associated with hepatitis C virus. The most important about Oral Lichen planus is the fact that it's a potentially malignant disorder, and hence it needs to be dealt with carefully, and the patient needs to be on follow-up for a long duration. So 0.5 to 2.2% of population is affected. If you look at this number, it might seem very small, but as a dentist, it's important for you to understand that many of these patients don't really come to you with Oral Lichen planus as the first sign or symptom, and many a time it is you who are actually diagnosing it in the first time. There's a high female predilection and the mean age is around 55 years. Now this is around the age of postmenopausal age. So that's why if you notice there's a very high tendency for females to be the patients whom you're likely to see in your clinic. The clinical features of Oral Lichen planus, there are generally 6 types of clinical features. Don't confuse them for histopathological features. These are classically clinical features, right? So you have both red as well as white appearing Oral Lichen planus. They are classified as reticulum or reticular type, where you see white striae or in an annular pattern. Papules, which are white, small white dots, also called as papular. Plaque-like, don't confuse for plaque-like lichen planus with leukoplakia. That's entirely different. Leukoplakia is a different disorder. We're not talking about it yet. So if you've noticed, I've put the first 3 in black and the rest in red. There's a reason to this. The bullous, erythematous or atrophic and ulcerative are extremely painful conditions, and hence they are symptomatic. The reticular, papular and the plaque-like are generally asymptomatic. Now it's not necessary the patient should always manifest with only one. You could have a combination of all of these at the same time, and it also indicates the disease is progressing. Now as a rule, generally lichen planus appears as reticular first and then only, or papular, reticular or papular first, and then only you see the rest of the types. So that means if it's moving from in this direction from white to red, you understand that the disease is progressing or severity of the disease is progressing. Right. So moving on. Let's look at some pictures of how lichen planus appears in the oral cavity. In this is a picture of a patient with bilateral reticular form of lichen planus. You can see the striae. You've learnt in year 3 that these are called as Wickham striae. Okay, you can also see that there are reticular form of lace-like pattern of white appearance on the lips of this patient. This is the papular form of oral lichen planus, where you see small white dot-like appearance, but somewhere here in the corner you see that there is also some sort of reticular network-like pattern. This is a case where you're seeing reticular type, white lines, striae along with erythematous areas. So this is an example to show what I just mentioned earlier, that the disease is probably progressing from starting off with white and then progressing with red areas. That means the patient is initially asymptomatic and turns symptomatic later on. Now how soon will the patient go from white to red, or white to mixed to red is very difficult to say. It could be months or even years. Examples of erythematous lichen planus, you would see that there are white areas and then there is central redness here. Similarly here also central redness with the surrounding white areas. So this is appearance of erythematous lichen planus. Now this is a very interesting terminology, desquamated gingivitis. This is not a diagnosis, but it's a clinical feature where you see erythematous areas mixed with white striae, erythematous areas mixed with white striae, and generally seen on the gingiva. That's why the term desquamated gingivitis. The gingiva is sensitive and peels off easily and is extremely painful condition. So the patient comes to you saying that, doctor, I'm not able to brush my teeth. When I brush my teeth, I end up with a lot of pain and I feel that my gums are peeling off. Please help me. What am I supposed to do? Right? Next is ulcerative lichen planus. So you can see that there's a large ulcer here, on the lateral border of the tongue and the buccal mucosa. You will also, if you observe carefully, you will also see that there are some striae seen on this part of the tongue and this part of the mucosa here. Some striae here as well. So like I told you, the reticular areas should be visible some part of the oral cavity to call it as oral lichen planus. Otherwise, you can easily confuse this appearance to ulcerative disease. Had you seen this patient only with ulcers, that means you've not seen this patient in the earlier form of the disease, but you're seeing the patient in an advanced form of the disease. Now, plaque type of lichen planus is very similar to homogeneous leukoplakia, very difficult to make out. But one giveaway would be that probably the patient could be female, or another giveaway, a clue to the diagnosis, which leads to the diagnosis, is the fact that lichen planus is always bilateral. Right, so this is a case where the plaque type of lichen planus is also developing ulcerative areas. If you notice in the corners over here, so suggesting disease progression. Now, lichen planus actually is a dermatological disorder. There are skin manifestations in 15% of cases which start off as oral lichen planus. Pruritus, erythema, violaceous papules. Violaceous means violet. Papules and plaques are seen. This is appearance on the skin. There's a very interesting terminology called as Cobner's phenomenon, which means that when skin gets traumatized, for example scratching, you end up getting a new lesion. Right? It can also happen in the oral cavity because there's constant trauma in the oral cavity during eating, during brushing. It might just aggravate the oral lichen planus. So does that mean that patients cannot eat and brush? Well, yes, they have to be careful while doing that, and it could be quite painful. Genital mucosal lesions are also seen in 20% of the women who manifest with oral lichen planus. So it's important to ask the patient if they have symptoms elsewhere. As a dentist, when you're looking at a patient and you're suspecting oral lichen planus, it's important to also ask the patient if they could be having any skin lesions or any genital lesions. So the diagnosis of oral lichen planus, to establish clinical diagnosis, it's important to see reticular or papillary lesions. Generally, lichen planus lesions are bilateral. Erythematous lichen planus can occur as desquamated gingivitis without white stripe. That means it could be completely red gingiva. And in these cases, you might need a biopsy for diagnosis if you're clueless as to why is it so erythematous and you're having other differential diagnosis in mind. Biopsy is important and should be taken from gingival pocket in this kind of situation. But if the lichen planus is on the buccal mucosa, then you would want to take a biopsy from the buccal mucosa. So that's about diagnosis of lichen planus. When we're talking about differential diagnosis, the many diseases come to mind. First of all, lichenoid contact reactions. I'll tell you what the lichenoid spectrum is a little later. You could look at restorations coming in contact with the buccal mucosa, for example, or the tongue, and leading to a lesion in that area. Generally a delayed hypersensitivity reaction kind of a thing. And it will have lichenoid reactions have the same clinical features and histopathology as lichen planus, but generally they are not generalized. They may be only located to one particular area and not bilateral or involving multiple areas like how lichen planus does. Lichenoid contact drug reaction, on the other hand, also resembles lichen planus, but it is more like a delayed hypersensitivity reaction. So the patient would generally have a history of a drug intake. It could even be a drug, it could be even a toothpaste, for example, a new toothpaste. So once you withdraw it, the lesions may subside. If it's not happening, you may have to do a patch test. So patch test, like many of you would have heard, is something done for testing a chemical, or it could even be a cosmetic product. It could be lipstick, for example, or it could be a dentifrice like toothpaste, or simply amalgam in the oral cavity. So in the current scenario, lichenoid reactions and lichen planus are clinically indistinguishable. That means looking at the lesion, it's very difficult to tell whether it's a lichen planus or lichenoid. There are only few giveaway features. That is, lichen planus is generally bilateral and lichenoid reaction is localized, and you would probably search for amalgam restoration, or probably a ceramic, a crown, or FPD beside the lesion, which is probably the etiology. So there are other differential diagnoses like oral graft versus host disease, but of course these patients would have a history of receiving a graft, and they have other features also accompanying. DLE, very difficult to differentiate from oral lichen planus. I will show you pictures later on. DLE is lupus erythematosus. Of course, a biopsy may need to be done to confirm the diagnosis. Again, homogeneous leukoplakia, like I showed you in the pictures, very difficult to differentiate plaque like oral lichen planus from homogeneous leukoplakia. The only giveaway again is the lichen planus is generally bilateral. Pemphigoid and pemphigus, these are vesiculobullous disorders, they are autoimmune diseases, and generally again difficult to make out when you're looking at ulcerative or erythematous oral lichen planus. So you might have to look for skin lesions, and of course a biopsy will help you reach the diagnosis. Erythema multiforme again also can look like desquamative gingivitis in the oral cavity, and again look like lichen planus, but it does not have any reticular area, so there are no white components in erythema multiforme, so that's the difference. So remember that to diagnose oral lichen planus clinically, I'm not talking about histopathology, clinically to suspect oral lichen planus, lesions need to be bilateral, you need to have a reticular area, and you need to search for the reticular area literally, and it generally will be bilateral. So this is a picture of lichenoid reaction pointed out in yellow. You can see here that it looks white on the outside, red in the center, and some grayish purple areas here. Very difficult to make out from lichen planus, looks exactly like lichen planus. But the only difference here is that there's an amalgam restoration which is on the buccal surface of this molar here, and another one here, which could be the reason why this patient is having a lichenoid contact reaction. So the lichenoid spectrum involves oral lichen planus, lichenoid contact reaction, lichenoid drug eruptions, and lichenoid reactions of both graft versus host disease. So we're not going to the entire details of this. What the slide is trying to, aiming to get you to understand is that the difference between the two diseases. Right, so when we're talking about treatment of oral lichen planus, our primary aim would be to reduce symptoms of the patient, right? So it's impossible to completely cure the patient. The only thing that we can do is to reduce the symptoms of the patient, right? So we still don't have a complete cure for these patients. So if the patient is asymptomatic, we wait and watch. So literally you're waiting for the patient to develop symptoms, and that's the matter of fact. Primary treatment of oral lichen planus is steroids. Now, for oral lesions, we always start with a topical steroid, and depending on the severity, either in the form of a mouthwash or a gel, minimum of 2 to 3 times a day application for at least 3 weeks. And then you taper the drug for 9 weeks. When we were talking about tapering of the drug, I'm taking you back to your pharmacology days, which means that steroid is can cause changes to the adrenal cortic complex. So that's why it's important that when the patient is put on steroids, you need to withdraw the patient from steroids slowly, and that is what is called as tapering of the drug, right? So generally you can't have oral lichen planus patients being treated for a few weeks and that's it, they get treated and stop. It doesn't happen that way. Most of the times the patients are on long-term follow-up, and they need to be followed up for quite some time to see that the patients don't develop any other lesion in the site, or the lesion is not progressing further, and you would want to see that the patient is symptom-free. Parallelly, treatment of fungal infection is important because we know that steroids, they cause local immune suppression. So when you have local immune suppression and anti-inflammatory action in the oral cavity, there is pain relief, yes, but along with it, the opportunistic infection like candida organisms tend to thrive and grow. So to avoid fungal infection, it's important that you simultaneously treat the patient with fungal infection so that he or she doesn't develop fungal infections in the oral cavity. Oral hygiene should be optimized before we start off steroids, so it's a good practice to do a scaling before you actually do put the patient on steroids, but sometimes you're looking at the patient in a situation where he's already very symptomatic, and hence you might want to do these simultaneously. Secondary phase of treatment, if the steroids are not working anymore, would be topical cyclophosphamide, tacrolimus, and retinoids. Of course, the patient should be medically fit to receive these medications. Most important thing is oral lichen planus is a potentially malignant disorder, and hence it has a malignant transformation rate of 0.2%. So it's important that the patient's symptoms are under control and the disease is monitored over a long period of time. What it actually means is that if in case you are seeing changes, then it's important to take a biopsy. Now, next is lupus. Now, lupus is going to be covered here as well as under the autoimmune disorders chapter. But let me give you a brief idea about lupus here. This is a multi-system autoimmune disease with formation of antibodies to DNA and involving immune complexes as well as B and T lymphocytes, leading to vasculitis. So, the primary ailment that happens in lupus is vasculitis. There are various factors which aggravate lupus erythematosus, and those are environmental factors such as sun exposure, some drugs, chemical substances and hormones. There is genetic predisposition, and generally females of reproductive age, that's 20 to 40-year-olds, are affected. African, the race is more affected than Asians and Caucasians. So, lupus is also known as a great mimic because it tends to manifest features which could be similar to many other diseases. I've discovered this before. The skin is affected in 85% of cases, and the common manifestation is a butterfly rash. You could also have renal, musculoskeletal, CNS and cardiovascular involvement. The different types of lupus erythematosus: SLE, DLE, acute cutaneous, subacute cutaneous. The most important out of all of this is the fact that it's a potentially malignant disorder when it happens in the oral cavity. As an example of malar rash, which is seen on patient here, is a typical classical example of systemic lupus erythematosus, rash developing on the malar region of the patient. Right, so SLE, DLE both have similar oral findings. Very difficult to tell you based on the oral findings itself whether you are looking at a SLE or a DLE. You might have to do more investigation to find out the systemic component of the disease. So, this oral manifestation may be the first sign of the disease. Now, that means in 20% of the cases, oral manifestations would be the first sign of the disease. That means as a dentist, you have a very high chance of catching this disease early. That is if the patient presents to you. White striae with radiating orientation, sharply demarcating at the center of the lesion. Central erythema is also present, which is called as brush border appearance. I mean, there's central redness, and on the periphery you have white striae. It looks like a brush. So the differential diagnosis for this appearance of the lesion is lichen planus again, aphthous ulcer if there is an ulceration present. Okay, so this is an example of how DLE looks like: central redness with periphery having white areas. Okay, so central redness looks very typical like a disc. That's why the term discoid lupus erythematosus, with peripheral white areas, so which looks like a brush border appearance, right? So like a brush border appearance. Some more pictures, again looking very disc-like or coin-like with brush-like white areas at the corner. Center is mostly red. But this one doesn't look like a disc, it just looks like irregular red areas with the little white brush areas. Now looking at this disease on this particular case, you can see both sides of the tongue, bilateral, is very difficult to tell whether this looks like erythematous lichen planus or DLE. And that's what we were trying to, the point I was trying to get to earlier. So now again, this is a case of SLE manifesting as desquamative gingivitis, extremely erythematous. Now looking at this, you cannot think of it as simple gingivitis, neither can you call it as periodontitis. There is so much of erythema of the gingiva, and it looks absolutely unexplained, right? So this type of manifestation is called as desquamative gingivitis. So again, let me remind you, desquamative gingivitis is a clinical finding and not a diagnosis on its own, right? So you could have even SLE which looks like desquamative gingivitis, lichen planus which looks like desquamative gingivitis, and to find out you will have to do a biopsy, and the best spot to do a biopsy from is somewhere near the pocket area. Right, there are 4 more criteria which must be positive in this American College of Rheumatology classification of criteria for SLE. Either a malar rash, discoid lesion, photosensitivity, presence of oral ulcers, that's the one which we were looking at earlier, non-erosive arthritis of 2 or more joints, serositis, renal disorders, neurological, hematological or immunological disorders, right? So the diagnosis of DLE could be well demarcated cutaneous lesions with scales and follicular plugging, that is malar rash. But in case when you don't have this and oral manifestations is first sign, then you know that you need to do a biopsy to confirm it. So systemic symptoms, in case of management of oral lesion, first of all systemic symptoms should be treated and symptomatic treatment administered. Again we go back to topical steroids and immune suppressive drugs, of course keeping in mind the opportunistic infections that may occur.